Assalamu alaikum. Warm greetings, everyone, and welcome to our Infinite webinar titled Sustaining HIV Impact in the MENA Community Coalitions and Regional Coordination and Leadership. My name is Dr. Dima Al-Bakri, a Senior Technical Officer in Infinite's Public Health Programs based in HQ here in Amman, Jordan, and I'll be your moderator for today. Today's session will be delivered in English with simultaneous interpretation in Arabic. Please select the preferred language from the channels below. Thank you for joining us from across the Eastern Mediterranean region and beyond, including colleagues from ministries of health, civil society organizations, academia, partners, students, public health professionals, and experts. This webinar is part of Infinite's monthly regional webinar series, and for today's session, we will focus on how to sustain HIV impact in the MENA region with a specific lens on the role of community coalitions, regional coordination and leadership, especially in a time where priorities compete and resources are limited. HIV remains a priority public health area across the region. Despite a relatively low HIV prevalence in the general population, our region has experienced about 60% increase in new HIV infections in the last decade, while the global trend is actually in decline. So this increase in our region reflects persistent gaps in diagnosis, treatment, and access to services, especially for key populations. At the same time, and on the bright side, multi-country and regional initiatives have shown how collaboration and shared learning can strengthen national efforts, especially when resources are constrained and the needs remain high. Community-led organizations and coalitions have also proven to be essential partners in bridging gaps, reaching underdeserved groups, and strengthening trust and advocating for more inclusive approaches. Before we begin, allow me to give you a few housekeeping notes. All participants will remain muted during the webinar. However, you are welcome to use the chat box to introduce yourself and to share any reflections, comments, and key points. Please use also the Q&A box to submit any questions you have at any time. We will address as many of them as possible during the Q&A segment by the end of the session. Now, to begin, allow me to introduce our first and keynote speaker, Dr. Mohammed Shahid Jamil, Technical Officer for HIV and Hepatitis at the Department of Communicable Diseases at WHO Regional Office for the Eastern Mediterranean region based in Cairo, Egypt. Dr. Jamil provides technical support to member states in the areas of HIV, hepatitis, and sexually transmitted infections, and supports the development of normative and operational guidelines and their adoption across the region. Today, he will set the scene by sharing a technical regional overview of HIV and AIDS in the region and the priorities moving forward. Dr. Jamil, you are welcome. You have 10 minutes and the floor is yours.
Thank you very much, Dina, for the kind introduction. Good morning, good afternoon, everyone. It is an absolute pleasure to be able to participate in this important webinar today, followed by a distinguished panel discussion. So in the next few minutes, I will give you a brief overview of HIV in terms of the epidemiology and situation in the Eastern Mediterranean region. In the WHO's Eastern Mediterranean region, we serve 22 member states, including occupied Palestinian territory. And this is quite a diverse region in terms of geography, stretching from Morocco in the west to Pakistan and Afghanistan in the east, and Somalia in the south. And it's a mix of countries which are high-income countries, some middle-income countries, and then we have some big low and middle-income countries as well. The region is characterized by several countries that are facing protected emergencies and humanitarian situations, which really puts the region in the context of in a unique context of competing priorities with limited resources, which makes the HIV response often quite challenging. Our epidemic is relatively lower compared to some of the other regions and concentrated in key populations, but it is the one that is steadily growing. We have in 2024 an estimated 610,000 people living with HIV, and this has nearly doubled in the past 10 years. And similarly, the number of new infections, as you have heard from in the introduction, has also doubled in the past 10 years. And this is contrary to the global trend of declining new infections. We are also seeing an increase in the AIDS-related deaths. So really, a concentrated epidemic in key population, which is rapidly growing. Our burden in the region is concentrated in some of the bigger countries. Pakistan alone accounts for 57% of the burden of HIV, and 5 additional countries, including Egypt, Iran, Sudan, Morocco, and Yemen, account for the remaining 33% of the burden. And then rest of the burden is concentrated in some of the relatively smaller countries. And this is also a representation of the varying population size of the countries as well in the region. When it comes to the testing and treatment coverage, the coverage of diagnosis, treatment, and viral suppression in people living with HIV, unfortunately, our region is lowest performing across all WHO regions. In 2024, only 37% of all estimated people living with HIV were diagnosed. 28% were on treatment and 21% had viral suppression. And this compares to 87% diagnosis coverage and 77% treatment coverage globally. And some of the regions are really now approaching 95 coverage targets. So really a lot of effort needed to expand testing and treatment services. Now, one of the reasons for low diagnosis coverage in our region is misaligned testing services in comparison to where there is the biggest burden and need, which, as I said, is usually among key populations in our region. So here, what I'm presenting is the number of tests that are conducted every year in our region, disaggregated by the different groups of populations or places where the testing is offered. And this is represented in the lower bar. The upper bar represents the number of diagnoses within the proportion of diagnosis within each of these groups. So on average, 6 million tests are conducted in our region annually. Only 6% of these tests are conducted among key populations. However, that 6% contributes to 50%, nearly 50% of all diagnosis. And then the vast majority of our testing is focused in some of the low-risk groups, such as travelers, migrants, for pre-employment purposes, visa-related testing, and premarital testing. So really, this mismatch between the testing and where there is need is contributing to this diagnosis gap. Also, in our region, we often see that there is, a slower uptake of new interventions, differentiated services, a service delivery model, and person-centered approaches. Here is one example showing the uptake of differentiated testing service delivery approaches in our region. And so the uptake of these services in national policies is often slow or lagging. So, for example, if you look at the community-based lay provider testing, which is a critical approach in expanding testing services, the uptake remains quite low. Also, for self-testing and network-based approaches, we see that the uptake in national policies is not there. And also, when countries have policies, it does not always directly reflect in implementation. So some of the countries that are doing self-testing or other approaches, they're not doing it at a scale that will have a meaningful impact on the epidemic. Um, because I mentioned that we have a rising number of new HIV infections in the region, so expanding prevention services is also critical. Unfortunately, the HIV response in the region is heavily donor dependent. There is very little, domestic financing for the response, and of the funds that are available, very little is prioritized for prevention, and this then gets reflected in the uptake and implementation of some of the critical prevention approaches. For example, uh, PrEP or pre-exposure prophylaxis and post-exposure prophylaxis is only available in 5 countries in the region. Harm reduction programs only exist in 5 countries, and also when they're implemented, as I said, the scale is quite limited. Um, Here is another overview of an area which is very important, which is the triple elimination of mother-to-child transmission of HIV, syphilis, and hepatitis B. This is a busy slide, but it gives you an overview of an assessment that was done in the region for EMTCT. And the graph here is presenting progress in the countries towards achieving impact targets that are required for elimination of mother-to-child transmission. I think the message here is that the progress varies quite a lot, but there are big gaps in HIV and syphilis. There is a bit more progress in terms of achieving hepatitis B target related to the zero prevalence. So we have some countries that are achieving or close to achieving those targets. But by and large, we see number one, gap in progress, but also in some instances, lack of availability of required surveillance data. Um, Not all is bad. So we have some really inspiring examples of success in the region. And just to highlight a few, we have some countries such as Morocco, Lebanon, Saudi Arabia, UAE, which are close to achieving the cascade targets, the 95, 95, 95 targets, or making good progress towards them. And in particularly in Lebanon and Morocco, there is strong element of community engagement and service delivery, as well as scaled implementation of new interventions such as self-testing and PrEP. Oman is the only country in the region to have achieved dual elimination of mother-to-child transmission of HIV and syphilis, but we have some other countries that are making progress and planning to submit for validation. In Egypt, although it's not directly related to HIV, but they have really scaled up hepatitis C testing and treatment and are the first country in the region to achieve the gold tier on the path to hepatitis C elimination. And that effort now is indirectly helping HIV in terms of scaling up harm reduction for people who inject drugs. And also we have countries such as Qatar and Saudi Arabia, which are moving towards integrated strategies for HIV, hepatitis, and STIs, and which can help more sort of integrated person-centered service delivery approaches to be available. And last but not the least, I think the engagement of civil society and community in designing and implementing and monitoring of programs is really critical, and we have often in our region gaps in this area, but it's really quite important. I'm glad that we are having this webinar today. Then just to sum up, as you've heard in the introduction and also in my presentation, the burden of HIV in Eastern Mediterranean region is rising sharply. Um, and despite this increase, prevention services and diagnosis, we see that there are big gaps, often because there is not good alignment and prioritization of populations that would benefit most. There is strong donor dependence and limited domestic resources in HIV response. However, there are significant opportunities, including for integration and success models that can be replicated across the region broadly. So this is an overview in a nutshell. I hope this was helpful and would help set the scene for the panel discussion. So I will stop here. Thanks for your attention and hand back over to the moderator.
Thank you so much, Dr. Jamil, for this comprehensive overview and for setting the stage so clearly. You did not just identify the gaps, but also highlighted areas of opportunity and also success stories that can be maybe replicated or learned from. So thank you so much. Your presentation highlighted the key priorities and will help frame today's discussion as well. So allow me to move forward for the panel discussion. We are honored to be joined by distinguished speakers representing regional coordination leadership, implementation experience, and also community coalition perspectives. Their insights will be very valuable in linking the technical priorities we just heard from Dr. Jamil to real operational realities, partnership models, and next steps for the region. A reminder to our audience, please share your questions throughout the discussion in the Q&A box at any time, indicating your name and institution if possible, and we will bring your questions into our conversation as we go along. We encourage also the panelists to reflect on each other's points to create a dynamic dialogue. So allow me to welcome the panel. First of all, we have Dr. Martin van den Boom. He's a physician with a PhD and a postdoctoral master's degree in public health. He also holds a degree in international economics. He joined WHO in 2008, and since then he has supported more than 40 member states globally across TB prevention and care, as well as HIV, hepatitis, STIs, COVID-19, and health system strengthening approaches. He currently serves as WHO Regional Advisor for TB, HIV, hepatitis, and STIs for the Eastern Mediterranean region based in Cairo. So welcome, Dr. Martin. Next, we have Professor Mohammed Shakroun. He's an infectious disease specialist and a professor at the Faculty of Medicine of Monastir, Tunisia, with extensive experience supporting HIV and STIs programming across the EMR. He has provided technical support for Tunisia's National AIDS Program, WHO, EMRO, and UNICEF. He currently serves as the chair of the CCM Tunisia, member of the Strategic Committee, as well as board member for the Eastern Mediterranean Region constituency at the Global Fund for AIDS, Tuberculosis, and Malaria. Welcome, Dr. Mohammed Shakroun. Next, we have Dr. Lama Majali. She is the lead program officer for IOM's Middle East response for TB, HIV, and malaria in Jordan and Palestine, supporting national programs to ensure migrant and refugee needs are integrated into health strategies. She leads efforts to strengthen systems and partnerships to improve detection, treatment, and prevention services, specifically for vulnerable populations. She brings strong regional public health experience from WFP, UNICEF, and WHO. Welcome, Dr. Laman. Next, Dr. Mohammed Al-Khammas. He is the president of the MENA-H Coalition, a leading network of community-based organizations across the MENA region, and a physician with over 20 years of experience advocating for human rights-based HIV response. As head of the international programs at ALCS Morocco, he has advanced key initiatives in HIV testing, psychological support, and harm reduction. Welcome, Dr. Mohammed. So, Dr. Mohammed Khammas, allow me to start with you as we speak. Speaking on behalf of MENA H, how can you tell us how MENA H has supported regional coordination and collective action among community organizations across different countries?
أسمح على أن سأتحدث باللغة العربية وهنالك ترجمة أظن. فلا يمكن الحديث على دور المناقش دون العودة إلى يعني تاريخ المجتمع المدني، أو كيف أن للمجتمع المدني أن قام بالمنطقة شمال إفريقيا والشرق الأوسط في إطار مكافحة الإيدز. أظن بأنه المناقش جاءت كفكرة تبلورت على ضوء ما قام به المجتمع المدني في مختلف الدول، أو الدول منطقة شمال إفريقيا والشرق الأوسط، التي لها الطابع الخصوصي على المستوى السياسي، على المستوى الثقافي. جميع الصعوبات المتعلقة بالوصم والتمييز والثقافة، إن صح التعبير، الثقافة الإسلامية، وما يترتب على ذلك من تمثلات خاطئة توصف الفئات المفتاحية بشتى الأوصاف. فكان دور المجتمع المدني على المستوى المحلي كانطلاقة شرارة للتعاون، أو للتعاون مع المؤسسات الرسمية وأصحاب المصلحة من أجل بلورة صوت الفئات المفتاحية. المناقشة جاءت بعد ذلك كثمرة كمشروع يحاول من خلاله بناء وتطوير يعني دور شبكة التي كانت تتواجد في منطقة شمال إفريقيا والشرق الأوسط، لكي تخلق نوعا من التواصل بين مختلف المنظمات المجتمعية في دول المنطقة، بحيث أنه يسمح بتبادل المعلومات، تبادل الخبرات بشكل منتظم ومنسق، كشكل من ستايل التعاون المشترك وتجنب تكرار المجهودات. حاولت مينا اش من مجموعة الأمور أنها تقوم على أساس من خلال دورات تدريبية، ورشات عمل إلى غير ذلك، لرفع كفاءات وقدرات العاملين في منظمات المجتمع المدني أو الممثلين الفئات أو القيادات من الفئات المجتمعية المعنية بالإيدز، والتي هي نوعا ما يعني تشكل زاوية العمل في إطار محاربة الإيدز. من خلال هذا المشروع حاولنا ما أمكن أن نشكل مجموعة ديال التحالفات، أن نحاول انتقاء قادة من المجتمع أو من الفئات المفتاحية الذين يكونون قادرين على تمثيل المصالح، القضايا، الصحة الجنسية، الوقاية من الإيدز، سواء على المستوى المحلي سواء على المستوى الإقليمي. وبذلك الآن نرى على المستوى الإقليم أن هنالك مجموعة من الشبكات المجتمعية التي تعنى بفئات معينة، لدرجة أنه الآن يعني نصل إلى مرحلة طلب التسجيل بعد تكوين القيادات. وهذه كلها أمور حاولنا ما أمكننا من خلال مجموعة ديال الأنشطة كما قلت، على أساس أنه نتعاون مع أصحاب المصلحة، مع ممثلين المجتمع المدني في مختلف الدول، على أساس مناقشة التحديات المشتركة، تنسيق الاستراتيجيات العملية والتشغيلية من أجل تعزيز واحد العمل جماعي وتكاملي بين مختلف الدول. وأكيد أنه الآن هناك مجموعة تحديات ممكن أن نتحدث عنها، ولكن كمناقش نعي جيدا أن دورنا يهتم بتقديم الدعم المستمر للمنظمات الشركة من أجل تطوير القدرات، من أجل استخدام الأدوات الحديثة، من أجل بلورة مجموعة ديال الخدمات حتى تصل وتستهدف تنطلق وتستهدف من الفئات الأكثر عرضة للإصابة، أو الفئات المفتاحية التي نسميها الفئات المفتاحية، حتى تكون البرامج والسياسات ذات طابع أو أثر فعلي تنطلق من المستهدف لتصل للمستهدف اللي هما الفئات المفتاحية. هذه بخلاصة يعني المشروع المناقش كتصور، كانطلاق عمل وتصور فعل تشاركي مع جميع أصحاب المصلحة على المستوى المحلي أو المستوى الإقليمي.
Thank you, Dr. Khammas, for highlighting the importance of having the civil society organizations being key to addressing such challenges. And as you said, that civil society organizations, as well as other stakeholders and partners, need to work together in order to ensure the strategies are impactful. So from there, allow me to go to Dr. Mohammed Shakroun. What do you have practical recommendations based on your experience to strengthen such regional coordination among CCMs, partners, and also civil society organizations and coalitions to protect the gains and to scale up the activities and the efforts, especially where we have limited resources?
Thank you. First of all, thank you very much for the invitation and the kind introduction. It is a great pleasure to be part of this webinar about HIV response in the MENA region. So to answer your question, to strengthen regional HIV response, coordination and leadership with limited resources, I believe that we need some special requirements at the country and regional levels, focusing on strengthening leadership and coordination. Firstly, the development of a robust national strategic plan provides a clear, actionable framework for addressing critical national priorities and filling gaps by coordinating, prioritizing, and implementing evidence-based high-impact intervention to ensure sustainable development. This national strategic plan must be accompanied by strong high-level political commitment, considering the HIV response as priority and ensuring domestic and external resource mobilization. The second requirement consists to establish and develop at country level a synergy between a national AIDS program, CCMs, and the local partners, including the principal recipient, to ensure shared responsibility and managing, monitoring, and leading the decision about an effective implementation. Thirdly, in the current landscape of limited resources and uncertainty, the region has not other than to work more effectively and in more coordinated manner. This means that we need to reinforce stronger communication, sustainable consultation, and ongoing collaboration between the different partners at country and regional level, including technical partners as UN agency, WHO, UNAIDS, IOM, CCMs at country levels, and regional NGOs, as well as Eastern Mediterranean constituency for the Global Fund, who will represent eligible countries receiving grants at the Global Fund, and represent these countries at the board and act as a channel for communication between the Secretariat of the Global Fund and the stakeholders on the ground. Constituency also contribute in shaping the Global Fund strategy, funding models, policy development, and ensure that the needs of key and vulnerable population are taken into account. And while this coordination already exists in the region, it should be reinforced and sustained. The first point is to enhancing collaboration and partnership by first strengthening community system and investing in the capacity of community-led and based organization to improve service delivery in the region. For example, for treatment, for adherence, for testing, for PrEP, and also by encouraging civil society and communities, regional networks to create a stronger, more united and efficient service provider network that fills gaps in care and harmonize strategy in order to optimize limited resources. Furthermore, collaboration between the government, the private sector, and civil society must be fostered to ensure that community-led solutions influence national policy. The fifth point is about catalytic investment. I think catalytic investments are very important in the current context in order to fill certain gaps not addressed in the country allocation. To this end, the multi-country MENA HIV grant should complete the country allocation. And in order to optimize the use of both allocation, country and regional allocations, strong coordination between the PR and SR and on the one hand, and the CCMs on the other hand, is crucial during the preparation and the implementation of the grant, as this would avoid unnecessary duplication of activities. Last but not least, we must build on the progress made in the region. And I believe that we have a very valuable opportunity to build on the progress and best practices achieved by some countries, as mentioned by Dr. Jamil's presentation. And this is in some domains, as treatment, triple elimination of vertical transmission of HIV, syphilis, and hepatitis B, integration and community engagement. And other countries in the region can learn valuable lessons from this, and we must create and promote opportunities to share these best practices and allow other countries to learn from. Thank you very much.
Thank you, Professor Shakrouni. Touched upon many areas I would like to take over to the discussion as we go forward. But I want to also highlight the joint robust strategic plans that at the regional level need to be implemented in order to synerge, as you said, allow me to quote you, for synergy and for harmonization. Allow me to go to Dr. Martin. We've discussed now, we've seen that we have different gaps, we have many challenges, and we also have some success stories. In your perspective, what are the most urgent priorities for sustaining HIV response, at least for the next phase for our region?
Thank you very much for the question, and allow me to also echo what previous speakers highlighted at the beginning of their respective interventions. I'd like to say that I feel extremely humbled and privileged to be a part of such a distinguished panel, and thank you very much for the invitation to this incredibly relevant and important event for our region. My colleague Dr. Jamil highlighted very convincingly that there's obviously a lot of need, that there is rising concern reflected by rising rates of HIV in the region. But also, and this is to answer in part already part of this first question addressed to me, what is it in our perspective what we can do, or in WHO perspective, especially for our region? And I would like to bridge onto one point that Professor Shakroun also made in his intervention. One key thing is that in order for us to be able to sustain success and impact is to share good and best practice examples along the entire cascade of HIV prevention and care. Because as we see, even though the light is dim and there's a lot of reason for concern, there are good practice examples and success stories. And often we have seen and we repeatedly realize in contact with our different collaborators within the network of international organizations, civil society organizations, but also and importantly at country level, that there are such good and best practice examples that others may not be aware of. So there is a lot of room for replication and making or adapting functioning or good practice works in other settings in the region and beyond. So this is one point. So this is also about information and knowledge sharing. One additional point also in line with previous panelists is that we have to do more and better in order to make sure that there is policy awareness and sustained political commitment. So HIV work, and I like very much Professor Shakroun's intervention also about this point of having, or there's need for very good policy documents, not just at global or regional levels, but country levels, national strategic plans. And these national strategic plans ideally be fully embedded in overall national health policies. So what we do see, and also this is especially in the current funding constraints and somewhat diminishing interest also in commitments towards HIV, is that the more HIV is an inherent part of national health policies, the better it is sustained and the better it can also not only survive, but sometimes thrive in crises such as this current one that we all currently in the humanitarian and public health setting. And also with this said, we need also more at the national levels and WHO, and we all can play our respective roles in that, is to make sure that there is more interministerial collaboration at country level. HIV is not just an issue that is purely limited to health. It is not biomedical only, but it goes beyond. It is also a social matter. It is a matter that relates to other aspects of life. So this is also something, and that links, of course, to the policy aspect. Now, when we come, and I will conclude with that also to technical aspects, of course, and we heard it as my colleague, Dr. Jamil, nicely and strikingly highlighted in his presentation, is also, we have to think about technical shifts also. When we see the yield from testing, we could shift, or we could do much more when we look at the key populations. So we need to enhance and increase the testing and the focus and the awareness for the need for testing in key population and taking care of our key populations. And this also coincides and must be coupled with strong and sustained destigmatization. And destigmatization is very important also, and increasing the testing. And of course, last but not least, the integration, the integrative aspect, especially when we think about community work. HIV is often not by itself, but it is also something that can be coupled, especially when we think about community work, with prevention or taking care of other diseases. So let's see if we can also seek further efficiency gains here. Thank you very much, and back to you.
Thank you, Dr. Martin. You actually touched upon some key priorities and also some challenges and gaps that we need to focus on. And as long as we're speaking about HIV, sustainability of HIV response, we cannot but highlight the vulnerabilities we have in the region. And here where I will come to you, Dr. Lama. How do mobility, displacement, and migration dynamics shape HIV vulnerabilities in the region? And how can regional coordination mechanisms better respond to this type of challenge?
Thank you, Dr. Dima, fellow panelists and respectful attendees. Well, HIV vulnerability is closely linked to patterns of mobility, displacement, and mixed migration flows. And I'm so happy that you're also touching on this and including this very important component, because people on the move often experience disrupted access to prevention and treatment services. And this is heightened by stigma, legal insecurities, and loss of social protection, all of which increase risk and undermine continuity of care. So this is particularly relevant in settings affected by conflict, as we see in the region, labor migration, and protracted displacement, where health systems are already under strain. What we constantly see is that mobility creates service fragmentation. So people fall between national systems when they move from one country to another. Eligibility frameworks, which is a very key and important point, and referral pathways. This is where regional coordination, and thank you for having this, setting up this webinar. This is where it becomes really essential and not only optional. Regional and multi-country initiatives, including those supported by a global fund, have demonstrated how coordinated approaches can reduce these gaps by different pathways, let's say. One is aligning minimum HIV service packages across countries, promoting sharing, and it was also mentioned by my panelist colleagues. So promoting shared learning on reaching underdeserved and mobile populations, in addition to strengthening referral and continuity mechanisms across borders. At the same time, and it's great to see the coalitions represented here in the panel. So community coalitions play a critical role in maintaining trust and reach, especially when stigma and legal barriers limit formal access. So strengthening regional leadership that brings together national programs, technical partners, and community networks is key to ensuring HIV responses are designed for mobility and not only for stable population. Thank you.
Thank you, Dr. Lama. As you said, integration at this point is necessity. It's not just an option. And thank you for highlighting the importance of having coalitions for gaining trust of communities. And here I would go to Dr. Mohammed Al-Khammas, representing such a strong coalition in the region. Dr. Khammas, where do you see gaps in how community perspectives are integrated and are included in regional HIV responses? And how can we strengthen meaningful community engagement on their behalf?
شكرا أختي ديما. في الحقيقة بالنسبة لي هو سؤال نسقي. تمظهرات أو الفجوات في إشراك أو في تمثيل وجهة نظر الفئات المفتاحية أو المجتمع المدني هي تمظهرات، ولكن حقيقة أو لب الإشكال هو الاعتراف بخبرة مؤسسات المجتمع المدني والفئات المفتاحية. للأسف ينظر إلى هذه الفئات وإلى المجتمع المدني على أساس أنه مقدم خدمات ربما، أو حلقة تستعمل عندما يكون هنالك إشكال معين في دولة معينة أو في تنزيل سياسة معينة، أو لا ينظر إلى المجتمع المدني أو إلى الفئات ممثلي أو الجمعيات المجتمعاتية التي تمثل الفئات المفتاحية على أساس أنها هي ذات خبرة ميدانية، هي تعي ما تريد وتستطيع أن تطور من أمورها لدرجة أن تصل أن تصبح ممولا للمعلومات أو المعلومات الاستراتيجية. الآن هنالك تطوير لما يسمى بالبحث المجتمعاتي، يعني community research، وهذا الأمر متطور بمعنى أنه نفس الحمولة العلمية التي تكتسيها الدراسات العلمية القوية الصلبة ذات أرضية أو طريقة علمية محضة، هنالك ما يقابلها على مستوى البحث المجتمعاتي الذي يطور المعلومة، يعطي يعني البحث زائد الذي يعطينا الفعل، ويكون الفعل استجابة لحقيقة الاحتياج الذي يحتاجه هذا المجتمع المدني. فبالتالي إذا نظرت الدول المنطقة أو نظرت المؤسسات أو أصحاب المصلحة رأوا في المجتمع المدني في الحقيقة أنه قائم بذاته، له خبرة، وممكن أن يبلور خبرات وأن يقدم مجموعة الأمور التي تستطيع تطوير استراتيجيات. آنذاك أتحدث على منطقة شمال إفريقيا والشرق الأوسط بالضبط ودولها، فآنذاك نستطيع أن نقول بأن ما يلي من الفجوات هي فقط تكملة أو تمظهرات ممكن السيطرة عليها. ومن بين هذه التمظهرات إذا أردنا أن نناقش على المستوى الميداني، ممكن أن أجملها في 4 أو 5 نقاط أساسية. النقطة الأولى تتعلق بضعف تمثيل المجتمع المدني في صنع القرار. أكيد أننا كلنا نتحدث جميع استراتيجيات الصندوق الدولي لمحاربة محاربة السيدا والملاريا والسل. منظمة الصحة العالمية تتحدث عن الصحة المجتمعاتية منذ المؤتمر 1978. كل يتحدث على الصحة المجتمعاتية، وأن المجتمعات لها دور في بلورة الاستراتيجيات، ولكن عندما ننزل إلى أرض الواقع نجد بأن هنالك ضعف، لأن غالبا ما تكون مشاركة المنظمات المجتمعية في عملية الإعداد الاستراتيجيات أو السياسات محدودة. يا إما أن تكون محدودة، يا إما أن تكون شكلية، وهذا هو الذي يؤثر أساسا في انعكاس حقيقي الاحتياجات وتطلعات الفئات في بلورة هذه الاستراتيجيات. فهذا أظن بالنسبة لي على مستوى يعني ما أعيه في بلورة الاستراتيجيات على مستوى دول المنطقة، هذا إشكال أو فجوة كبيرة. المسألة التالية أو الفجوة الأخرى ممكن أن نقول بأنه عنده علاقة بغياب ديال التواصل، والتواصل يعني غياب قنوات تواصل شفافة ومفعلة وفاعلة. لأنه الآليات، وإن تحدثنا عن مثلا لجنة التنسيق الوطنية إلى غير ذلك كشكل من أشكال تنزيل المنح للصندوق الدولي إلى غير ذلك، فهي تبقى على اعتبار أنني أنا عضو، حتى أنا عضو في لجنة التنسيق الوطنية في المغرب، فهي تبقى آليات غير منتظمة وواضحة المعالم بشكل كبير، التي تسمح للمجتمعات المحلية بنقل صوتها وملاحظتها في صناعة القرار بشكل مباشر وموثوق، مما يعكس غالبا الاستجابه للاحتياجات الحقيقيه التي تعطينا يعني اثر واضح على المستوى الميداني، وهو الصوره التي قدمها لنا الاستاذ جميل من خلال المداخله الاولى. حتى على مستوى آلية المساءلة كفجوة أخرى، المساءلة والفعالية، كل يتحدث على إشراك المجتمع المدني، ولكن مؤخرا الصندوق الدولي لمحاربة السل والملاريا والإيدز يعني يحاول بلورة أداة لتقييم دور المجتمع المدني في التفعيل جيد جدا، ولكن إلى حدود اللحظة ليست هنالك أدوات للمساءلة والشفافية حول فعليا هل هنالك إشراك الفعلي لاحتياجات المجتمع المدني والفئات المفتاحية في صلب السياسات وبلورتها والتتبع ديالها وتنزيلها إلى غير ذلك. هذا الشق المتعلق بالآخر إن صح التعبير، يعني بالأطراف الأخرى. إذا رجعنا للمجتمع المدني يجب أن نكون صراحة، ويجب أن نكون واضحين. حتى المجتمع المدني فيه إشكال، لأن هنالك حاجز ضعف القدرات ديال المجتمع المدني، ويجب أن نقولها بصدق. نحن نتحمل، لا يمكن أن نلوم الآخر دون أن نلوم أنفسنا كمجتمع مدني. حتى المجتمع المدني من فجوة أنه هنالك او ممثلي الفئات المفتاحيه هنالك ضعف في القدرات ديالهم، التي تحتاج مجموعه من النشطاء والمنظمات لدعم اضافي لتطوير القدرات الفنيه واساسا السياسيه، حتى يتمكنوا من ممارسه الدور الفعال، خاصه في التفاوض والمناصره وتاثير في الاستراتيجيات. واظن بان النقطه اللي تحدث عنها الزملاء كامل، اغلب الزملاء المتحدثين قبلي، تبقى حتى الافتقار للتمويل المستدام. هذا من الفجوه الذي يؤثر على السيروره الطبيعيه للمجتمع المدني والشبكات المتعلقه بالفئات المفتاحيه. اغلب التمويلات تمويلات لحظيه واجنبيه، ولا تستجيب للحاجيات الحقيقيه لهذه المؤسسات، مما يؤثر على استدامه العمل واستدامه التطور والتطوير ديالهم كمؤسسات المجتمع المدني. فأظن هذه خلاصة أهم الفجوات التي يمكن أن نتحدث عنها علاقة بدور المجتمع المدني في إنجاح السياسات المتعلقة بالحد من انتشار الفيروس.
شكرا دكتور محمد الخماس. Thank you Dr. محمد الخماس. Thank you for also highlighting the donor-dependent financing system and how can this affect sustainability. Before I go into this point, I wanted to focus more on the inclusion of civil society organizations in service delivery and even in decision-making. Professor Shakroun, what do you think or how can you think regional coalitions and partnerships and learning hubs or platforms, how do they align with the WHO? Apologies, I have this question prepared for Dr. Martin, because I wanted to align the inclusion of the coalitions and other regional platforms or learning hubs into WHO technical guidance to promote evidence-informed, coherent, and harmonized HIV programming across countries.
Sorry, thank you very much. I was muted, and thank you very much for this very relevant question. And indeed, I was really very attentively listening to my colleague, Dr. Hamas, because he really has a very good point. And as WHO, I would like to welcome this point and appreciate and recognize it very much. That still to date, there is unfortunately a limited, how to say, involvement, or let me say it differently. There is still much more, or the benefit of civil society organizations in the fight and in the work for HIV is much higher, or there is a lot of benefit that is still not fully recognized by everyone that should be recognizing. That is one thing. And also in one part, this applies certainly to us. It also applies to national stakeholders. What I'm saying it is that, and I'm coming back to my previous point in good and best practice examples, especially now in this very challenged funding and humanitarian landscape, there is even more room for civil societies to come in. There is even more room for civil societies to be involved, and Dr. Hamas is very right. There's a wealth of knowledge and experience on the side of civil society organizations who have been working and who work every day in the front rows and on the front line in not just making experiences, but in also sharing experiences, in caring for the patients, and also in generating evidence. So he is very right in that we should all be more diligent on our commitment of involving and including civil society organizations, also in policy making and in through their contributions of evidence generation, of experience making on the ground. That is one thing. So that point is well heard. The second thing, and just to let you know that, of course, WHO has in recent years been making efforts in enhancing this involvement, but we can still certainly also do more there. So the point is well heard. In saying that, that's for policy development. That's also for development of technical guidance, certainly. And that also comes and goes in line and goes hand in hand with such events like this one. So we need multi-partner and multi-coalition events such as this one, also where we share knowledge, where we have dialogues, where there is exchange. And that is also why I am purposefully deviating a little bit from the script that I have, because I was asked to be a bit more interactive. So we're trying also to have a dialogue and to speak to one another. And I think this is really a very relevant and thus a very useful event in that respect. Last but not least, I think, in this crisis that we're currently facing in the humanitarian and public health landscape, I know it's often said as something that we may not, or that sounds a little bit abstract, but it is true that each crisis also holds opportunity. So I think also that this crisis holds opportunity and what we have been pleading for, and so to say, preaching within parentheses over many years. I've been privileged now to be in public health for 20 years. Many here have been longer there. So And it's not a question of the time, but what I'm saying is crisis also brings opportunity for change. Because thinking outside of the box and being innovative, and not just thinking outside of the box, but acting outside of the standard box of our, let's say, conventions, is really requested right now. It's brought upon us by circumstances. So I think that is also an opportunity to rethink how we operate and how we work. So all suggestions on our side are very welcome, because we all realize we cannot work as much or as business as usual. And one additional point also, again, to pick up a point of Dr. Hamas, he's very right. I think our role as WHO is also that we continue to advocate for or helping civil society organizations, being the extended arms or the collaborating partners, not just by us, but also by national stakeholders, ministries, in playing their part, their complementing part, their catalytic part, their contribution, together with academia and, of course, the governments in caring for our patients that we all serve and care for together. Thank you very much, and back to you.
First of all, thank you for your optimism in seeing opportunity in such crisis. This is really a nice way of seeing a place for change and doing change, and also for highlighting the importance of such dialogue and such conversation we're having today, because these extend beyond such webinar. These are conversations on collaboration and coordinating efforts even. And moving forward, I would want to hear from Dr. Lama's IOM experience on cross-border collaboration and regional coordination like this one. How does it strengthen continuity of HIV prevention and care for mobile and specifically hard-to-reach population?
Thank you, Dr. Dima. I think this panel by itself is a good example of collaboration in the region. WHO colleagues bring technical expertise and are, in fact, advisors for the Middle East response that is led by IOM. The MENA-H coalition brings together CSOs and networks that we as well in Jordan work closely with. Dr. Shakroun, for example, brought a wealth of expertise and supported Jordan in updating ART guidelines. So these are positive experiences that in the short period that I served with IOM, I witnessed. Coming to IOM's experience across the region, cross-border collaboration does strengthen response by shifting from isolated, let's say, national efforts to a more coherent regional system of care. Let me give an example that is not HIV specific, but more TB specific, as we as well work on this, that we can also replicate for HIV. We had a cross-border TB SOPs that were recently developed, and it was led by Dr. Martin here in the call, by the, let's see, Syria plus regional countries, which is an amazing, let's say, example of how the different actors come together, the different UN agencies, national partners, etc. They have a conversation together, and we really touch on practical challenges, and we keep the conversation going, and we really put some tangible steps on how to address this. So for Jordan specifically, we developed our own HIV SOPs for the returnees, so for the Syrians returning to Syria. However, again, this is very context specific because the prevalence in Jordan is quite low, similar to, relevant to other countries. So each country needs to really look at its own context, its own numbers, and act accordingly. So I will as well, follow into the footsteps of Dr. Martin and deviate from my talking points into more practical, let's say, example. one of which is the Global Fund multi-country initiatives in the region, which have clearly shown that cross-border collaboration leads to more coherent, resilient and sustainable HIV response. Again, when technical partners and community actors are meaningfully integrated into coordination mechanisms. And I think Dr. Dima and the Infinite team can agree that the initiatives that are funded by the Global Fund, the Middle East Response, and the MC MENA, encouraged our bilateral communication and collaboration, which we are very pleased with, and seeing the results on the ground already. We had our own conversations on the side, and sometimes like these really small discussions can open new channels for us to deliver care, and one of which how now through our Infinite colleagues and their presence as well in Gaza, we're now having it's opening new ideas for us, new channels and new pathways for us to deliver the care that is needed. Thank you.
Thank you, Dr. Lama, for giving us examples from the field and real-life collaboration experiences we're experiencing, even here, participants from the panel. And also touching upon the financial constraints raised earlier by other panelists. I want to highlight the importance of our collaboration, of course, and the activities we're conducting together for the HIV response. Professor Mohammed Shakroun, speaking on which, and we know that we have a global fund cycle coming ahead, what are key expectations or requirements should countries keep in their mind in the upcoming funding period?
Thank you very much for the question. It's a very topical question. For the upcoming Global Fund grant cycle, that means the cycle, grant cycle 8, countries in the MENA region must prepare for reduced allocation, increased sustainability requirements, and stronger focus on transitioning to domestic funding. Where possible, data-driven approach is crucial, as I mentioned. Data from IBBS, from key population size estimation, stigma index, the active HIV database, and other national studies is vital for informing funding requests and guiding high-impact intervention and investment decision. It is valuable to have data because some of them can be used in a qualitative adjustment to determine whether to increase the formula-derived amount. And this is very important for countries. So there is an opportunity to increase the amount of the allocation through this data. Where feasible, a robust national strategic plan for HIV, or better for integrated national strategic plan for HIV and other diseases, are essential to organize a unified or united evidence-based response to reduce new HIV infection, morbidity, and mortality by 2030. National strategic plan should address the following area: key and vulnerable population, including young women, adolescent girls, and displaced people. This is very important, as highlighted by our colleague Lama. The continuum of care and ensuring the continuity of essential services, including HIV prevention. And HIV prevention now should include innovative approaches for combination HIV prevention, in particular injectable PrEP. And now we are talking about lenacapavir PrEP. We have to focus also on testing, on treatment, and the long-term care and the prevention with clear milestone to achieve 2030 goals for ending AIDS as a public health threat. Sustainability and integration are very important, and we need to focus on strengthening, health systems, promoting community-led response, and integrating HIV services into primary health care. Unfortunately, developing a national strategic plan is often not possible in some countries with a challenging operating environment or those affected by conflict. And in this area, the main priority are maintaining essential services as multi-month dispensing antiretroviral, community-based testing, and ensuring retention in care. Due to anticipated lower allocation, countries should focus on remaining competitive by rigorous prioritization and value for money. This is very important. So funding requests must focus on essential services, as I mentioned, on high impact intervention, as scaling up HIV testing, treatment, and PrEP, and evidence-based intervention and other to offer maximum cost effectiveness. Strengthening also resilient and sustainability system for health by integrating HIV services in primary health care, moving towards the implementation of the triple elimination of vertical transmission of HIV, syphilis, and hepatitis B is a good example of integration and that we can start with. Also, we need to consider to integrate community-led response and utilizing pooled procurement to make health communities more cost-effective and prevent any shortage. Sustainability and transition planning, this is very important given the financial constraint of GC8 countries must demonstrate how they will sustain programs through domestic resources and increased co-financing. And countries, particularly those with higher income status, should anticipate accelerated transition and plan for long-term financial self-reliance. Countries are also encouraged to be proactive, and CCMs must start planning early country dialogue and collecting relevant data to inform funding requests and select the appropriate submission window. I will stop there, and I can share more information if needed through questions. Over to you.
Thank you, Professor Shakrun, for highlighting these recommendations. And I will move to the questions and answers box and try to answer as many questions from the audience. And also Professor Shakrun had mentioned the integration of HIV services into primary healthcare. So I would open this question to any panelists who would like to respond. There's a question on how to ensure that these HIV services are integrated into primary healthcare, are actually integrated rather than being vertical programs and easy to cut. The panelist who wants to answer, just feel free to answer.
Well, that's a bit of a $1 million question, but let me jump into the breach. I will not say I have an answer to that $1 million question, but I will start. And maybe what also, again, helps is that, information sharing, knowledge sharing, and experience sharing. And that also, of course, applies to for governments, meaning that we have seen not just with health, but that governments who collaborate with governments of other countries that maybe, let me say, a bit more advanced in de-verticalizing their systems, health systems. We know that when we look at the globe, some countries, it always goes in waves. In waves. So we have empires or countries, in a way, systems rising, and then there's a time of high affluence, and often then there is decline. What I'm saying is that some countries may currently be more, so to say, advanced as we see it with integration of HIV services in primary healthcare services. and that often goes also for other disease areas, not just HIV. And what can help is that there is exchange between politicians, decision makers, policy makers from or between those countries. So learning, and we try from WHO, of course, to also facilitate that and provide platforms for learning. And that is one thing we can do, or we can support. Another thing, of course, is that we do have examples also at national levels then where there are efficiency gains that are made by integrating previously more verticalized entities such as HIV in overall primary healthcare systems. But of course, this takes time and effort, and often it is not an easy process, I must admit. And there are often also setbacks. It doesn't immediately show success, but it is a process, of course, where especially inter-country learning and exchange can help. But just this jumping into a breach, maybe some other panelists would like to complement. Over. Thank you.
Thank you, Dr. Martin. I would like to take another question from the panel. We keep highlighting the importance of regional coalitions and coordinations, yet HIV incidents and AIDS-related deaths are continuing to rise. So the question here is, where is the failure occurring? At which level of evidence generation? Is it policy? Is it financing? Or is it maybe a collection of these factors? Yes, Professor Shakroun.
Thank you very much. Let me add something on what Dr. Martin said. I agree with him. Integration needs time, needs efforts. It's not easy process. But also what I wanted to add is in our regional context, we need to be careful about integration in setting where stigma and discrimination are prevalent and where the health system's capacities is insufficient. Because integration aims to improve equity and quality of services and not undermine them. Thank you. Over to you.
Thank you, Professor Shakroun. Dr. Khamas?
شكرا أختي ديما. أنا لن أعلق على مداخلتي الأساتذة القبلي، ولكن سأحاول أن أجيب على المداخلة أين الخلل، أو السؤال أين الخلل بمنظور واقعي وبمنظور مجتمعاتي. وأظن بأن تدخلي أنا متأكد جدا بأنه سيخلخل التمثلات. الخلل بالنسبة لي هو في منطقة شمال إفريقيا وشمال إفريقيا والشرق الأوسط، هو أننا نتبنى سياسة النعامة. بمعنى آخر، أو طبيا بعلم النفسي سكيزوفرينيا. عندنا تمثل ثقافي ديني بين مزدوجتين يؤصل السياسات ويربي المواطن في المنطقة على أساس توجه أو تمثل يعني معين، بينما الممارسات والواقع شيء آخر. يعني هذا الإشكال هو الخلل. الخلل عندما نعي جيدا أن ما نتبناه كثقافة، أنا هنا لا أصنف ثقافة إيجابية أو ثقافة سلبية حقيقية، أو ليس هنا في الجزم، ولكن أن نعي أن الواقع تطور، وأن الإشكال موجود، وأن ما نراه نحن تمثلا الواقع يكذبه. فبالتالي إذا كنا نريد أن يكون لنا أثرا حقيقيا وأن تكون لنا استراتيجيات فعالة، يجب أن تنبني على براغماتية علمية. البراغماتية العلمية تقول بأننا إلى الآن لا نصنف سياساتنا بالشكل المدمج الذي يستجيب للتطور العلمي من ناحية، لما يقع على المستوى المحلي أو الوبائي بكل دولة، فكيف يريد التدخل أن يكون مطابقا للواقع المحلي أو الوطني للوباء كإيدز، ليكون التدخل بشكل مستمر. بالله عليك، كيف يمكن، أنا لن أشير إلى الدول ولكن أعي ما أقول، كيف لنا أن نقول بأننا نسبة، مثلا عندنا نسبة، أقول أرقام حتى لا وصلنا، لا أعطي الأرقام الحقيقية لبعض الدول، نقول بأننا وصلنا إلى 95% أو 90% من 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 الحالات الحاملة للفيروس شخصت، مع العلم أن عدد المراكز التي تقوم بالتشخيص على المستوى الوطني الذي يتجاوز الآلاف الكيلومترات المربعة لا يتجاوز أصابع اليدين، ونقول أننا وصلنا ل 95. فهل هذه معطيات؟ كيف يعقل أننا في سنة 2026 لازلنا نتحدث عن التشخيص الطبي ولا نتحدث عن التشخيص المجتمعي الذي يقوم به المجتمع أو يعني الفئات المكونين أكيد بتكوين إلى غير ذلك في إطار استراتيجية الكشف المجتمعاتي. كيف أننا نتحدث أننا وصلنا إلى 95% في التشخيص أو 80% في التشخيص، ونحن لسنا لم نستعمل بعد التشخيص الذاتي، لم نطور استراتيجية المتحركة للتشخيص، لم نستعمل الأدوات يعني السوشيال ميديا لجلب الانتباه أو للوصول للخدمات التشخيص فمجموعة ديال الأمور. فهذه كلها أمور تمثل خلل حقيقي ينطلق من تمثل خاطئ بين السياسة وبين واقع، وهذا أنا بالنسبة لي هو المحدد الأساسي. إن وعت الشعوب هذا الأمر، أكيد أن التدخلات والاستراتيجيات ستتغير وستكون أكثر ملائمة للواقع.
Thank you, Dr. Hamas. So I think that you do agree it's multifactorial, but also the factor of this gap and other cultural factors as well are contributing. And I saw also a question and a comment regarding to stigma. Maybe we can go back to in the following discussion. However, I found this question, I think it's relevant to you, Lama. I think it's quite interesting that as we discuss people on the move and health and equity, and we've seen also the presentation about UAE and Qatar's positive achievements. So there's not always gaps. There's also some kind of positive examples. How can we advocate these countries' policies in terms of, for example, mandatory HIV testing and automatic deportation to the region?
Thank you, Dr. Dima. And it's an important question, and it's a point that always comes. And I knew this was coming, and it's always the debate, if I may say, and especially for Jordan. So speaking about policies first, so the policies, if we may say, that restrict residency or movement based on health status can significantly undermine HIV prevention and treatment outcomes, as we all know. So from a public health perspective, the fear of deportation, and as we see on the ground, discourages people from testing, which is a crisis, if I may say. It also delays care, and it increases treatment interruptions, which can be drastic as well. IOM's role is not to set national policies, but to support government with evidence, regional learnings, and practical approaches that can protect the continuity of care while as well respecting national frameworks. So it's a difficult balance, if I may say. So in our region, we work with different partners, and we also rely on civil society coalitions to promote access to confidential and non-discriminatory services, strengthen referral and continuity mechanisms for mobile populations, and of course, continue to support the dialogue on health inclusive approaches that improve public health outcomes. What consistently emerges is that enabling access to HIV services, specifically for mobile populations, strengthens epidemic control and is more cost effective in the long term. From IOM's side, again, so we support governments with the technical guidance and practical solutions. An example from other countries that really succeeded to overcome this, to protect continuity of services while as well working within the national frameworks and not overstepping the national ecosystem. Thank you.
Thank you, Dr. Lama. I think this does clarify some points. Again, I wanted to touch upon an area that was discussed earlier regarding health financing, and as international donors transitions out of some of the MENA region, what domestic financing mechanisms can be created to ensure these coalitions remain funded and remain strong and sustainable? So I think this is a point that matters to all of us. Another $1 million question.
Maybe we can hear Dima from the coalition representation to hear from their point of view, and then maybe we can complement.
لا هو يعني مسألة تأمين المصادر التمويل أو يعني البحث عن تمويلات مستقرة ومستدامة، زعما حتى نكون بوضوح، لا يمكن أن نبنيها أو تبنى هذه السياسة ديال البحث عن التمويل دون الحديث عن تمويلات محلية. عندما نتحدث عن محلية سواء داخل البلدان منطقة الشرق الأوسط أو شمال إفريقيا، أو على المستوى الإقليمي منطقة المينا، من خلال الدول التي تعتبر دول غنية، ومن خلال المؤسسات التي يعني لها إمكانية التمويل لهذا الأمر. ولكن الإشكال الذي يطرح في هذا النطاق كمجتمع مدني هو إلى أي حد الدول أو سياسات الدول المنطقة، حتى لا نكون في تصور إقليمي ننطلق من الوحدة اللي هي الدولة، إلى أي حد الدول تعتبر حقيقة بأن المجتمع المدني مجتمع مدني الذي يعمل في مجال الإيدز أو الصحة الجنسية والإنجابية للشباب، أو بما فيه التعفنات المنقولة الجنسية، الالتهابات الكبدية، الإيدز إلى غير ذلك، إلى أي حد ممكن أن تكون شريك وأن تدخل في إطار سياسة الدولة. ربما بمعرفتي المنطقة، ربما على مستوى المغرب نقد أن نقول بأنه القوانين متقدمة جدا في هذا المجال، ولكن في مجموعة ديال الدول لا زالوا بعيدين جدا، بل بالعكس هنالك مجموعة من الدول التي تعي بأن المجتمع المدني تمويلها مصادر تمويلها مصادر خارجية، وتحاول حتى هذه الصنابير التمويلية الخارجية تحاول أن تقوم بسدها. فهذا إشكال جوهري. المجتمع المدني أكيد أنه يعي جيدا بأنه التمويل يجب أن ينصب على التمويل المحلي والتمويل الإقليمي. هنالك تمويلات، هنالك موارد، هنالك حتى الدراسات التي قمنا بها مثلا في المغرب اثبتت الجدوى، اثبتت بان دولارا لو تم يعني صرفه في اطار منحه او في اطار عمل وقائي من خلال المجتمع المدني ممكن ان يعود بالافاده على الدوله ب 19 دولار. وهذه دراسه يعني حديثه قامت بها وزاره الصحه. فجميع الامور يعني تقول بانه دور المجتمع المدني مهم، إلا أنه الإشكال المطروح هي هل سياسة الدولة تواكب هذا الأمر. نتحدث عن السياسة الصحية عموما. الميزانية الدول، أغلب الدول لا تستوفي المعايير التي تفرضها أو تطلبها منظمة الصحة العالمية، أغلب الدول إلا استثناء في منطقة شمال إفريقيا والشرق الأوسط. هذا على مستوى الصحة، السياسة الصحية للدولة. فما بالك إذا جزأنا ودخلنا إلى تمويل المجتمع المدني في إطار هذه السياسة هذه؟ فهو إشكال. إذا كان الأمر يعني صعبا على مستوى الدولة أو سياسة الدولة، فهو أصعب بكثير على مستوى المجتمع المدني، وهذا تحدي. وفي المناقش ناعم لأنه هذا الأمر ديال التمويل والبحث عن التمويلات المحلية أكيد أنه أولوية من الأولويات. فيه مجموعة ديال الأمور يجب أن توازي هذا البحث عن التمويل، بما في ذلك بناء قدرات المجتمع المدني خصوصا على مستوى الحوكمة، على مستوى السياسات، يعني تقوية القدرات ديالها على مستوى السياسات والمراقبة والتتبع وإدارة الموارد، حتى تكون قادرة أن تدخل في في شراكات مع الوزارات او الوزارات الماليه، وزاره العلائم المموله. فهذا الشيء كله نعيه جيدا، ولكن نعيب لانه حمل ثقيل، لانه الاولويه عند الدول لا زالت الى الان هي الصحه العامه باشكالاتها الكبرى، دون الحديث عن الصحة المجتمعاتية التي يجب أن تدخل في سياسة الدولة وأن تتبناها الدولة ليكون التمويل مستمرا.
Thank you, Dr. Khamas. And the financing challenge remains a challenge in addition to the other challenges that have been raised up during this panel, but also it all comes to collaboration and coordination in order to overcome such challenges. So for final remarks, as we come to the close of our webinar, I would want to hear, I think, an answer to this question by each of the panelists. So speaking on the importance of collaborations and coordinations, if you recommend one practical step in order to strengthen regional coordination between all involved actors, the community, the national programs, international partners, technical partners, and experts and donors, what would it be? And if you have a closing remark, please include this with your answer. So,
على السريع
تفضل.
إلى انفينيت كبي اتش أو متلقي رئيسي في إطار المنحة الإقليمية، كفاعل على المستوى الإقليمي من خلال المجموعة ديال البلدان وعلاقات مع وزارات إلى غير ذلك، نتبنى أو توصية أساسية هو الاعتراف بخبرة المجتمع المدني والفئات المفتاحية وكشركاء في السياسات والاستراتيجيات كشركاء حقيقيين. هذه التوصية.
Thank you, Dr. Khamas. The importance of recognizing the importance of all stakeholders involved and all partners with their whatever differences they bring to the table. Thank you, Dr. Khamas. Professor Shakroun, I see you nodding. Yes.
Thank you very much. Just I would like before my closing words, giving some answer about domestic funding, and I think. One of requirement of Global Fund is co-financing, and co-financing is a kind of domestic funding. And many countries are not fulfilling this requirement. And I think they can start to be engaged on this way of co-financing and to progressively increase the co-financing. And this is a very good exercise for transition. So just a short answer for this question. As closing words, I would emphasize 4 keywords. First one is prioritization. I think it's time to think differently, to plan differently, and to implement also differently. So we have to prioritize. And I agree with Dr. Martin. He said, we have to think out of the box. Like it's time, because it's not time now to do business as usual. We have to think differently. So we have to prioritize, we have to integrate, and we discuss it about integration. We have to be more efficient. That means the ability to do tasks well, successfully, without waste, even if limited resources. And we need also self-reliance. That means the quality of depending on ourselves for planning, for implementing, instead of relying on others. My last point is about an opportunity. We have to take the opportunity to move forward in approach for prevention. And lenacapavir is a good opportunity. It's a very effective tool to reduce new HIV infections. And lenacapavir will be available soon at affordable price. And I encourage countries to plan to have lenacapavir as a prevention tool. I know it's time, so thank you very much. And
thank you so much for the recommendation, Professor Shakroun. Thank you a lot. Dr. Lama, I would like to hear from you briefly. You have 1 minute.
So, yeah, I'll be very quick. So my final points will be recommendation would be investing in community and efficient use of resources. So when these are connected regionally through the coalitions and the support by national programs and other actors will definitely improve the continuity of care and have the resources go further. One thing as well, if I may, is the use of available resources, and it was mentioned before, like the pooled procurement platforms is an important and efficient platform, and the advancement that we see now in testing and diagnosis. And let's also please keep in mind that mobility is and will remain a defining feature of this region. And the question is not whether people will move, it's whether our systems are designed to move with them. That's why regional coordination and community leadership are what makes that possible. Thank you all.
Thank you, Dr. Lama. And last but not least, Dr. Martin, in 1 minute, please.
Thank you very much. I'll try my best. You asked for some pragmatism, so just a few points. Indeed, let us see and let us be adaptive to realities. So one thing on the policy side and commitment side, and we heard it before, there is now increased need for increased responsibility by all of us in our respective roles. This is a crisis, and we have to all do more, and we have to also do differently and more innovatively. This also applies to national governments. There is need for more and for more sustained domestic financing and commitment. Just one example. The second thing is also, let's think opportunities. Let's think about, when we think about migration, complex emergencies, protracted emergencies, let's think also about further digitalization, digital support to patients, and also artificial intelligence, a big elephant in the room that we can make use of. And the last point is also, let's be pragmatic in sharing and never tire good practice examples, and then also coordinating more and communicating very proactively with one another. And this is a very good approach. I'm very grateful for this event. Let's have more of that. Thank you very much, and back to you.
Thank you for these insights, and allow me on behalf of INFNET to extend our sincere thanks for you as distinguished speakers, and to all our participants for being very engaged. I've seen the questions and answers box, and as well as the chat box very alive. We also want to welcome any follow-up discussions and opportunities for regional collaboration, whether through knowledge exchange, coordinating advocacy, or even joint programming. So we hope the session has contributed to shared learning and generated practical ideas for collaboration and next steps for our region and probably beyond. So allow me to conclude today's webinar, and thank you everyone once again, and goodbye.
شكرا.
Thank you.
Thank you.
Salam.
Bye.